I'm Kirsty Cummings. I'm the Chief Executive at Community Leisure UK, and we're delighted to be hosting this webinar today, but we have also invited in some of our partner organisations as well. So we've circulated the invite for this across our membership, but also through some of our local authority partner networks as well across England, Scotland and Wales. So we should have a range of different colleagues and different perspectives coming into today's webinar. We are recording it, as I said, so it will be available as a resource afterwards if you want to listen back, or if you want to share with colleagues who are maybe not able to join us today, then that will be available as a resource and hopefully a bit of a reference point as well. And I guess kind of kicking off is a little bit of, why we're hosting this. Exercise referral within our membership has been a really a significant topic over quite a period of time. We've been involved through our members with discussions around exercise referral, different approaches to exercise referral, and ways of coordinating and improving some of the impact, and also articulating the impact of exercise referral. So hopefully today we'll get a bit of a spotlight on different approaches and some of the evidence that sits behind that, which will feed into a lot of the conversations that many of you have been involved in through various different networks as well. So a really kind of timely and opportune opportunity for us to host this webinar. But really we are not the stars of the show by any means. We're probably never the stars of the show, but we're really just facilitating in the background for our colleagues from FIRST. So we have a number of colleagues who will introduce themselves as their various presentations take place. But just to give you a bit of background, so FIRST stands for the Public Health Intervention Responsive Studies team. So that's an NIHR funded initiative which supports evaluations within local governments right across the UK. So there are 10 FIRST research teams. Each one works with 10 different local governments to evaluate one of their public health programmes. And the process is a competitive one for local governments where they put in an expression of interest, which is then shortlisted by NIHR. So that gives you a little bit of kind of background. Doesn't do it quite justice in terms of understanding the scale and reach of the organisation. But again, hopefully just provides a little bit of a flavour as to who is going to be leading us through the next hour or so of our webinar. And today we've got 3 different teams from within FIRST who'll be presenting on 3 different exercise referral evaluations. Some of you will have seen kind of very short synopsis of those that we've circulated with the webinar invite, just to give you the kind of headline of the 3 different approaches and give you an idea of some of the content that'll be covered today. But the focus, and speaking with colleagues at FIRST, is very much about the takeaways of each evaluation. So it's taking that evaluation and learning, and then understanding actually how does that translate into practice for some of you. And I think we'd be really keen to hear any reflections as well, either on the webinar today or following up around actually, any thoughts that have been triggered and what that means for your own approach to exercise referral at a local level. So without further ado, I'm going to hand over to our first presenter, to Neil, who's going to lead us through the next kind of 10-15 minutes or so on the presentation. So over to you, Neil.
Thanks, Kirsty. Yeah, I'm going to try and stick to about 6 minutes, I think, for the slides, and then a couple of minutes for questions. So thank you for having me today. I've had a nice explanation of what the FIRST teams are. I'm representing First Connect here, which is primarily based at the University of Hertfordshire. And obviously this evaluation was done by a big team there. And it basically covers the Welsh National Exercise Referral Scheme, which I'll be referring to as NIHR from now on for short. And this evaluation in particular was about adaptations made during COVID and throughout the pandemic. So away from face-to-face to online, and then a sort of hybrid model. Okay, next slide, please. Okay, so small bit of background on NIHR. It's a national level program, and it's got 11 different pathways, and these are primarily for people who have long-term conditions or are living with them or are at risk of. So there's some treatment and rehabilitation pathways, and that's things like back care, stroke, even sort of cancer rehabilitation in an appropriate setting. And then there's the more prevention-focused pathways, which are generally more from primary care, GP referrals, and there's a sort of generic pathway for that as well. So it covers quite a few different conditions. So there's the initial referral from a sort of health professional, and then at the first consultation, which is a chance to sort of do some measurements for the program. So they've got a national database that capture things like physical activity levels, other health metrics, and then they talk about the sorts of goals that the service users might have throughout the program. They then get 16 weeks of supervised exercise. They agree in principle to do sort of twice a week for 16 weeks, and then they have a 16-week consultation, which is sort of catch up about their goals, and then they repeat those physical activity and health measurements both at the 16-week consultation and then at a year's time. So up until March 2020, when the pandemic really hit in full, it was just face-to-face group classes. And then in the year following that, they offered for everyone who'd done 4 weeks of the face-to-face classes, so it got used to it, they offered a virtual option or an exercise from home option. And then from March 2021 onwards, there was this sort of flexible hybrid option where people could choose to either do virtual or face-to-face or a combination of both. Next slide, please, Sarah. Okay, so what did we find? Attendance was highest for the flexible delivery, so giving people that choice between doing virtual or face-to-face. Uptake and adherence. So uptake is sort of attending the first consultation and the first exercise session, and adherence is sort of carrying it through, to quite a few exercise sessions, and then the 16-week follow-up. So that was better adherence, and uptake was associated with being older and living in an area with lower deprivation. So there's some inequality issues there. Contrary to what we thought we might find, actually delivering a virtual program is quite a lot more expensive, and we'll talk about why. This is generally related to having 2 registered exercise professionals in the room for safety, online in the room, and having to limit the number of service users that are in that virtual room, again for safety issues, particularly on the sort of secondary care referral pathways where health issues are a real must in terms of safety. So offering a virtual version did, however, reach people that might not have reached before. So this might have been people living in rural areas that can't make it to the face-to-face sessions, people living with disability or other caring responsibilities. However, particularly older service users really struggled with digital skills or confidence to get online, and therefore it could exclude people with sort of low digital literacy. So some real considerations there. Next slide, please. Okay, so in terms of recommendations that we made, and this was sort of one of the infographics we did at the time, is a recommendation to provide a mixed model of delivery if possible. We've seen some of the beneficial elements of virtual delivery and the kind of accessibility and reach that might produce, but also maintaining that face-to-face for people's preferred mode of delivery. So older adults, people that really enjoy that social support, the wraparound part, meeting for coffee and other things after. Obviously, from my research hat on, I always encourage people to monitor the effect of providing a mixed model in terms of uptake, adherence, and outcomes. And again, uptake was both accepting the referrals to going to the first consultation and also going to the first exercise class, because there tends to be attrition or drop off at each of those time points. And adherence was how many sessions did they go to in the 16 weeks and did they do the follow-up? Okay, as much as possible to try to seek to deliver equivalent experience, particularly the social elements of the program. I think it's really tricky. I think anyone who does online meetings for work, it is really hard to sort of get to know people a bit more. It's more sort of focused on the business at hand, and so for those exercise sessions, trying to provide some wraparound social element, sort of equivalence of the face-to-face is quite important. If you are thinking about commissioning or running programs with pathways for referrals from secondary care, so quite serious ongoing conditions, then balancing safety and sort of good results is really important on those online sessions. So the way we costed up was 2 exercise referral professionals in each session, so one's delivering, one's monitoring, which is a lot harder to do when you're not in the room, and then capping the amount of service users. So that's what makes it more expensive. Trying to implement strategies to reduce inequality. So we've already mentioned that doing an online version might get people from rural areas, might get people who won't be able to make it to the face-to-face, that have other responsibilities. It might, increase accessibility and equity for those people. However, do monitor digital accessibility, particularly for older service users. Now, they did experience sort of good uptake, but that's going to be for the ones that are confident. We've done other research and other evaluations that shows digital exclusion for that demographic. So that's it for now. Hopefully that was on time.
Thank you, Neil. Yeah, you were very on time, which is great. So hopefully, folks, that was kind of a really interesting kind of insight. I certainly was listening very interested, kind of linking, I suppose, what you said to actually some of the discussions that we've heard through our networks as well, and kind of seeing the parallels, which is always interesting to see in some of the discussions, particularly as we went through the kind of COVID period as well, and how to change models of delivery and kind of embrace a new normal very quickly, and then some of the concerns that came through around that. Actually, I think you kind of captured some of those in your summary there as well. So we'll have time at the end of all three presentations for kind of full questions. So again, if there's things that pop into people's head, please pop them in the chat or kind of store them up for the end. But just a couple of questions on the back of your presentation, Neil, if that's okay. So
Sure.
I guess just the first one is, kind of looking at sort of the future of exercise referral schemes. In your view, should people be thinking about commissioning and planning online sessions as part of exercise referral schemes going forward?
I would say yes, if it's possible. I know there's some challenges with the cost. If you're doing more generic prevention focused exercise referral schemes, so, GP referral, people at risk of a lot of sort of, let's say at risk of CVD, for instance, not any really serious health challenges, then you might be able to loosen those sort of safety restraints on the online program. So have a higher cap for the number of people. Maybe it's okay to have one exercise referral professional. So that could make it quite a bit cheaper potentially to run those online sessions. But I think if you're going to, one of the big criticisms of exercise referral schemes is that they might not address sort of health inequalities potentially, because the people that are able to and are motivated to end up attending and kind of engaging. And so offering that mixed model can try and mitigate some of those, criticism or challenges. And so I think if possible, it's a really good idea.
Excellent. Thanks, Neil. And then just a sort of second question before we hop on. Just, I guess thinking about the whole systems approach, which is very much, that kind of approach that seems to have been coming into play right across the UK in slightly different ways, but certainly a lot of conversations around systems, complex systems, and where kind of exercise leisure fits into some of those systems. But with a kind of view on referral schemes, where do you see exercise referral schemes fitting with that whole systems approach?
Yeah, it's a good question. I sort of when I'm lecturing, I kind of do some content on this sort of false dichotomy or false separation of individual level approaches versus population level approaches. And I think it's sort of a false one. I think, you should have a lot of moving parts in a system. Let's call it a physical activity whole systems approach for this example. It should have a lot of moving parts that address different elements of the system. And I think an exercise referral scheme can fit in to that approach. The NIHR, for instance, is a national level. So you've got Public Health Wales, the Welsh Local Government Association, you've got a lot of different leisure providers, lots of referral from primary, secondary care, and then exercise referral professionals that come from a lot of backgrounds. So there's a lot of joint working already in there. It's a smaller system than a whole systems approach, but it is a system with a lot of collaboration, a lot of cross-sector working already. So it's already a good example of that. But I would always advise that if you're going to do a whole systems approach to physical activity, that, there's a lot of other things you can address at a population and environmental level, uh, safe streets and parks for walking and, leisure time activity, appropriate cycle lane provision, incentives for sort of active travel, designing the built environment, even green and blue spaces, so parks and canals and things like that, where people sort of socialize and walk through communities to make sure that they're set up for physical activity as well. So there's a lot of other elements that you can't address with a exercise referral scheme, but I'm of the opinion that it can play an important part as one of those cogs.
Thanks, Neil. And I guess what might be interesting is, towards the end of the webinar, we've got a bit of discussion time. I know there's a number of colleagues on the call who are involved with both exercise referral, but also kind of in those conversations about whole systems approach, and maybe some reflections from kind of live examples might be really interesting as well. But we'll kind of put a pause on that just to make sure that we're a-okay for time. So thank you so much, Neil. I think that was a really insightful presentation, and for taking the questions as well. We'll hop on now to our second presentation, but for those that have just joined us, so just a reminder, if you could pop into the chat your name, your organisation, your kind of interest and your role related to exercise referral, and what you hope to get from today's webinar. It's just useful for us to be able to kind of understand the audience that's here today. So if you've just joined us and you missed that at the start, then please pop that into the chat when you've got a chance. And I see, Sarah, that you've also kind of popped into the chat the full evaluation link as well. So we'll circulate that after the webinar today, just to make sure that people have sight of that. But it is there if people want to look it up. If you're inspired straight away after today's presentation, then it's there. You don't have to wait for us to send that out. So moving swiftly on to our second presentation with more of a focus around tackling inequalities, I'm going to hand over to Susie and to Emma, please. Thank you.
Thanks, Kirsty. It's going to be me. I'm Susie Sykes. I'm Professor of Public Health and Health Promotion at First South Bank. So I'm talking on behalf of our whole team that were involved in one of our evaluations into a targeted exercise referral scheme that was deliberately developed in order to reduce inequalities. So thank you. Next slide. So a little bit about the intervention. It was a service based on a traditional model of exercise referral, but which built in some novel features that were deliberately designed to help reduce health inequalities. And as such, it was framed as a wellbeing service rather than just purely being about exercise. So those novel features, just to kind of unpack some of them, it followed a principle of proportionate universalism. So that means it was a universal offer open to everyone, but with extra support and targeting for those in greatest need. And the way it delivered some of that additional support and targeting, the access was made free of charge for people in certain categories receiving benefits. And the service was particularly targeted at those living in more deprived communities and people with protected characteristics. The referral routes were also intentionally broad, so referrals could be made not just by health professionals, but also by social prescribers, the voluntary sector, wider professionals working in the community, and even self-referral, so very broad referral pathways. After an initial assessment with a health and wellbeing physical activity coach, each participant received a tailored and bespoke plan. And the intention was that plan wasn't necessarily gym-based, so it could include one-to-one or small group sessions, or it could also include activity and sessions based in the community, so community walking groups and other activities delivered perhaps by the voluntary sector. Another key difference was the length, so delivered over a 6-month period rather than the usual 12 weeks. And the extended period was designed to help people make more sustainable changes. And finally, the ambition was that the health and wellbeing coaches weren't just intended to be exercise instructors. They were expected to link participants with those wider community services, so also make onward referrals where health-related needs were identified, and that could have been around housing, debt advice, or support for loneliness and so on. So it was framed as more than an exercise programme, conceived as a kind of a wellbeing intervention that tried to connect some of those social determinants of health. Thanks. Next slide, please. So a little bit about what we found. We did see a very strong initial uptake, so 320 people referred and 80% engaged, which is in line with national exercise referral data. And it was partly successful in reaching that target group of those from economically deprived neighbourhoods. About 40% came from those areas, and those with long-term conditions who were most likely to be inactive. We did collect some data from people living in those target neighbourhoods who hadn't accessed the service, and that showed awareness of the scheme was quite low, and it was less successful in reaching ethnic minority communities and the most sedentary. The majority of users were women, an average age of about 51. But participation and adherence was low for some groups. So only around 15% of participants met the recommended level of 2 or more exercise sessions a week. But those that engaged, they had multiple and very complex health conditions, often both physical and mental. And many had complex caring responsibilities, unstable life circumstances, creating substantial barriers to that adherence. So those that completed the 6-month intervention reported modest but important shifts in health, well-being and lifestyle, including feeling happier, increased confidence, resilience, reduced social isolation. And there were improvements in self-reported physical health and fitness. But for some of the participants, the intervention, those improvements were quite small. With limited reports of weight loss, but some changes in eating habits. So a complicated picture, if you like. But participants did tell us about the things that helped them join and stay involved. And they did report that those features that were the scheme's in kind of novel features were those things that helped them get involved. So the free or subsidised access, seen as a really important enabler. The longer 6-month offer, another important enabler, and also a personalised coaching relationship was valued. But we did find some systemic barriers and some challenges in meeting the overall ambition that the project had set itself. So the cross-sector connections were very limited. Referrals came almost entirely from the health professionals, rather than from that wider set of referrers that had been hoped for. And the referrals outwards from the health and wellbeing coach did not largely take place. So while the programme had intended to include that community-based activity alongside the gym-based activity, I think in practice it was heavily gym-based, which may have narrowed accessibility. So that ambition of a broad community-embedded model, I think we would conclude was partly realised. We also did a simple cost analysis, which showed that the cost per participant was £172.40. So next slide, what does this mean for you? So we're going to focus on 6 key lessons really for practitioners and commissioners alike. So first of all, the free or subsidised access really matters. Even a small cost is enough to deter people on the lowest incomes. Secondly, extending that duration beyond the typical 12 weeks also gave people time to stabilise their lives, build confidence and experience those tangible benefits. We saw many people with complex health conditions who had to stop participation due to treatment and so on, but really wanted the opportunity to re-engage that extended window gave them. Thirdly, the health and wellbeing coach, that role was seen as really crucial. Their relationship, the continuity of that role, and the skill in motivational support were what drove engagement, and more could be made of that role in order to enhance that wellbeing community embedded focus. Fourth, needs a really strong referral networks and also feedback loops between services. So referrers need to know what happens after they refer, and the scheme needs to stay really visible to them in order to maintain that referral. Fifth, the opportunity to move beyond gyms was seen as really important. So those, as I've said, the community, the outdoor, the social options were seen as really essential for enabling inclusion and for embedding that physical activity into daily life. And finally, I think, as was just mentioned in that last question, that exercise referral schemes should be seen as part of a wider physical activity system and not simply a standalone service. So that means commissioning with equity, inclusion, sustainability and systems in mind, rather than seeing this as a single service. So I'll stop there. Hopefully that was 6 minutes as well.
I mean, to be honest, I wasn't timing it because I was kind of too busy listening to what you were saying, which was fascinating. But we're still on track for timing, so I feel like my chairing is still okay. But thank you so much for that. I mean, as you were talking, I could hear a lot of the conversations that we've kind of heard through our membership echoing, and I think there'll be a lot of thoughts pinging from those that are on the call. Particularly we've had lengthy discussions around, kind of free, subsidised access, what does charging look like, the differences across different schemes, time frame has come up again and again, as well as many of the other items. So there's lots of thoughts and lots of questions, but I'll keep it kind of very brief and then we can open up at the end. So I guess just kind of following up, I mean, firstly, what do you think were the barriers and the facilitators that disadvantaged underserved groups that when they were accessing exercise referral?
Yeah, we did a lot of qualitative data collection with participants at the beginning of their journey, halfway through and towards the end. So they told us lots of stories about the enablers and barriers to accessing the service, and they were kind of what you'd expect when inequities are structural and not individual. So for those most underserved groups, I think the main barriers that they talked about were cost, time, transport and complex living circumstances. People told stories of very complicated life circumstances, caring responsibilities, unstable employment that didn't allow them to access the gym when they wanted to, managing multiple health conditions for themselves and also for their wider family. So the location of the scheme came up very often. So for some of them, it was quite a distance to travel and required perhaps 2 buses. And that definitely limited access for those without transport and reinforced the sense that this was a gym offer and not a community offer, if you like. But on the other hand, the facilitators around the free or subsidised access and that 6-month duration, those elements kind of gave people both permission and also capacity to participate. I think it enabled them where they needed to step out and back in again without having to go back to the beginning of a referral pathway. And I think that was really important for lots of people that we spoke to.
Thank you. I think that's incredibly interesting. And again, a lot of things are kind of resonating with, maybe some of the anecdotal things that we've heard, but hearing it obviously from a much more robust evaluation perspective is really fascinating. Conscious of time, so I'm going to hop us straight on to the third of our presentations on hub-based models and hand over to Sarah.
Yep. Hi, everyone. I'm Sarah. I'm part of the First Elevate research team. So we're based in Edinburgh. And we just finished an evaluation of a hub-based model for exercise referral in Southwark in London. And when I say hub-based model, what I mean is sort of a single point of access for referrers, or if you self-refer, and through that single point of access, you're then referred on to the exercise program or other program, which might be best for you. And just to give a bit of background on Southwark, it's a borough of London, about 300,000 residents and very ethnically diverse. So about 25% of residents are born outside of the UK. And in terms of physical activity and weight, 1/3 of adults, so just talking about adults here, are physically inactive, and about half of the adult population live with obesity. So the intervention that we looked at is called the Integrated Healthy Lifestyle Service. So as I mentioned, there's a hub, and people can either self-refer into the hub, or it's primary care or social prescribing can also refer into the hub. The hub then, kind of triages, refers on to different programs. One was a child and weight management program, a child and family weight management program. And one was exercise on referral with 3 different intensities for adults. And there was also a number of other services that the hub could refer on to. So things like health walks, stop smoking services, talking therapies, also national diabetes prevention programs. But we didn't really look at that. What we looked at were the hub, the Child and Weight Management Programme, and the Exercise on Referral Programme that the Hub referred on to. And these were all 3 commissioned by Southwark Council. So apart from the 12-week programmes, these were all 12 weeks, there was also signposting and support after the programme. So for example, free gym and swim options or discounted gym membership. So that was the intervention that we looked at, and we specifically looked at whether the hub or referral through that hub makes it easier for people to access these exercise programs. So what did we find? So, I mean, I know it's a vague statement, and I can explain more if there's questions, but the hub improves access for some. However, the way the hub engages with service users could be smoother. And with that, I mean things like wait times were not really standardized. There was no expectation management in terms of what service users might be, referred on to, expected. A lot of people thought it was, like personal training or things like that. So, there was not much engagement, expectation management, and also the role of the hub was not always clear for service users. So the hub in this case was a telephone-based service, and they weren't always clear who was calling them, why they were calling, and how that differed from the program that they were referred to. And a really important point, probably one of the main points, is to do with integration, so that the hub needs to be integrated with other parts of the service. And that's especially true with data, but it's also true for things like post-program support that I was talking about. So what does this mean for you? So if you're considering, things to consider when introducing hub models is definitely what are inclusion and exclusion criteria for referral into the hub? Can people self-refer into the hub? And then what exercise programs does the hub refer into? So for our evaluation, there was for the intervention we looked at, there were a set number of programs that the hub referred into. I know that for the recommissioning process, they wanted to review it, make the hub, expand the role of the hub, make it more of a single point of access. And then talking about standardizing the referral process, including wait times, including expectation management. How do you best do that? And then a really important point is, I think, how do you present and communicate the hub to service users? Do you want to make it an obvious thing? Is the hub something that is advertised, communicated, or is the hub more something in the background and it happens without service users really being aware of it too much? And then really important, how do you link data between the hub, the different exercise programs, and possible leisure centre data, especially if third-party providers are involved? And then also, how do you link with ongoing support and signposting to post-programme options? So I feel like I spoke really quickly there. I hope that was 6 minutes, but I'm happy to take any questions.
Super, thank you, Sarah. And again, yeah, I think you're spot on in terms of timing. So you're making my job as chair incredibly easy, which is delightful. So maybe just a couple of questions for you, and then we'll open it out. So I'm going to give people the kind of heads up that we're going to open it out for your questions in just a couple of minutes. So have your thinking caps on. I'm sure you've all got plenty of thinking going on. But Sarah, just kind of following up on that, what other functions could these hub-based models have that are beyond referral, in your opinion?
I think that's a really interesting question. And the hub, we did a rapid review of hubs and had a look at what functions hubs could have as part of this project. And the primary aim is the single point of access and the referral onwards, but they can also have functions like, they can triage referrals, they can be a single point for data collection and follow-ups as well. If programs have a sort of, a 4, 8, and 12-week follow-up, that could be coordinated through the hub. And the hub itself could also have a bit of a behavior change function as well, through doing things like motivational interviewing or something as part of the hub offer. So it loads of functions. It would also depend on exactly what the hub looks like. The one we had here was a telephone-based service. I know you can also have proper physical hubs in the community, which then could act as things like warm spaces as well, or something to do with more like a community, a proper community space on asset. So yeah, lots of functions. It really depends on what is needed.
Super, thank you, Sarah. It'd be interesting again to hear from people on the call, what their approach is that kind of resonate with this, and also some of those, other functions I think have been kind of replicated in various ways across different schemes, which is interesting. Just one kind of final question before we open out. What considerations, Sarah, are there if the hub or any kind of part of the exercise referral scheme is run by a third-party provider? And I guess that might be particularly relevant for some of the people on the call today.
Yeah, that's great. That's so we had that. So if I go back to this slide, the hub, the child and family weight management and exercise on referral were run by a third-party provider, and the main issues that we found there was the last point that we on this slide, which was to do with kind of the integration of the data and the post-program support. So I mean, you've basically got the staff that are running these 12-week programs side by side in the leisure centres with leisure centre staff that are not running the programs. So that we found in this instance there wasn't that much there wasn't that much exchange of knowledge. People didn't really know the other people, which led then to there was not consistent signposting to post-program support, which could be done by leisure centre staff and the people that are running the exercise referral programs. So there wasn't that. There wasn't sort of the data was different. So the data from what the third party provider had was very different from leisure centre access data. So there was limited amount of linkage or follow up. So it's just those sort of things that you really need to consider when you're working with another party.
Super, thank you. So you'll have seen in the chat, hopefully, that we've popped in, I say we, but they've popped into the links for the full evaluations for each of those examples that have been presented on today. Again, we can circulate those after the webinar today. But just also a flag that actually FIRST is got a wealth of evaluation knowledge. There's over 50 completed evaluations which are on the FIRST website, and there's more that are regularly being added into that, and you can filter on those by location and topic. So please do take a look and use that as an ongoing source of information, and again we can circulate the link to that as well. So thank you all for your time. I appreciate diaries are always busy, but the number of people we've had on today shows the level of interest in this area, which is great. And there's some links and contact details on the screen as well from our speakers. So if you want to follow up, I'm assuming that you'd be very happy to receive emails from people on the call. I'm kind of volunteering your kind of follow up with speakers, but hopefully that's okay. And a huge thank you to everyone, and any kind of questions, reflections, please let us know afterwards. Please pop it into the chat. So thank you all and have a good rest of your day, folks. Take care.